Hello, welcome to your lecture on Bell's palsy. Bell's palsy is basically a paralysis or weakness of the facial nerve, which is your seventh cranial nerve. So a patient's going to come in with this weakness of the seventh cranial nerve. It's almost always going to be unilateral. We usually treat it with corticosteroids, and most patients over a period of time have a pretty good recovery. Now, when someone comes in with this facial paralysis, about 70% of the time it's going to be Bell's palsy. 30% of the time it won't be. So this lecture, I hope, will kind of concentrate on, how do you know for sure it is Bell's palsy, and when do you start to think that it's maybe that other 30% that you need to refer. So hopefully we can do a good job of that with this lecture. Now, when it comes to the epidemiology of Bell's palsy, most of the time it's idiopathic, which we really have no idea what causes it. But all the newest research is pointing to the herpes virus, and that has really kind of affected our treatment plan. We know that family history plays a part. If they have a family history of this, they're about 10% more likely for this to be Bell's palsy. And remember, what we're looking for is whatever increases the likelihood that this is Bell's palsy. So, if they've had a previous episode of this, of course, they're more likely that this is Bell's palsy. If you ask them about recent infections, like upper respiratory infections, then, that increases the chance that this is Bell's palsy. Anything that has recently decreased their immune system, a new diagnosis of HIV, of course, those sorts of things would increase the risk of it being Bell's palsy. And that's another reason decreased immunity is why it's so prevalent with someone who has diabetes. With pregnancy, there's also a threefold increase, and I'm not sure what the pathophysiology is there. I haven't seen much in the readings regarding it. Most common ages are 15 to 45, and there's a peak in the 30s. Now, this is actually pretty rare. I've been practicing for 15 years. I haven't seen this. So this may not be something that you see very often, but it's when you do see it, I hope that you can recognize it pretty quickly and immediately. So questions to ask, and again, we're trying to rule out that 30% of it not being Bell's palsy. And like we said, this is mostly a young population that comes in, so you're going to immediately think, okay, this is probably Bell's palsy, but these are some things that you really need to ask to help rule out some of your differentials. So, which muscles are affected? Because with Bell's palsy, you're going to have unilateral facial paresis, and that's the norm for patients with Bell's palsy. But no other limbs should be affected. So if they tell you that they also have, right-sided weakness, or they're having gait problems or something like that, this is not Bell's palsy, and you need to be looking, other places. Did this happen gradually? Bell's palsy is very much an acute onset. It happens over a period of days, usually overnight, and it comes on pretty suddenly. So if somebody comes in and says, well, I've noticed, this is a problem and it's been kind of gradually happening over the last month or so and it's getting worse and that's why I'm here today, then that's not going to be Bell's palsy. Ask about whether or not they're able to close their eyes and whether there's pain with that. And sometimes you need eye protection, and if a patient's having any problems with their eyes at all, go ahead and get a referral and get some help with that. We don't know that it's going to get worse, but we don't know that it's going to get better, that there's not some type of abrasion or something there already. So what other medical problems do you have? And again, we're thinking about, okay, have they been ill recently? What things do they have, like diabetes, that are maybe contributing to the fact that this could be Bell's palsy? Again, we're really trying to rule it in. We're trying to rule out other things, but we're really trying to make ourselves feel completely comfortable that this is Bell's palsy, because we don't want to do $1 million workup on this young, healthy person. Some medical issues you probably wouldn't want to use steroids with, or If you do, then you're going to have to, make sure, like if it's your diabetes, to keep an eye on that as well. Have you had any exposure to a tick? So Lyme disease is going to be a very reasonable differential for this particular problem when they come in with the facial paralysis. And we talked about them being ill recently, and again, that's infections and those sorts of things that may predispose them to Bell's palsy. Is your taste the same? Sometimes with Bell's palsy, they'll have a reduced taste sensation. So that's something to ask. Does noise bother you? Pain is due to involvement of the facial nerve branch, and loud noises tend to bother them more. So these are some things that you really want to ask. And again, we're trying to rule in Bell's palsy. All right, with your objective data, some of the symptoms that they're going to come in are saying, they're going to say that they have some weakness, that they have some facial numbness, maybe a sensation of fullness around the mastoid process on the affected side. You may notice some tearing or watering on the affected side. They can talk about loss of taste. They may say that there's some numbness, but just kind of tease that out a little bit and see if there's any like sensory loss there, or if it's really just like a tingling sensation, because that can be pretty common. So what you're looking for is your mouth is going to be drawn away kind of at the affected side, when you smile. And I know you guys have seen this before. Drooping eyebrow on the affected side. You're going to have loss of the nasolabial fold and loss of forehead furring. F-U-R-R-O-W-I-N-G. I'm sorry, my country accent's coming out a little bit. I just cannot say that word. You may have a wider palpebral fissure on the affected side and drooping lower eyelid, and again, some tearing on that side. With the weakness, you can ask the patient to raise their eyebrow or to frown, and they should not be able to do that. They're probably going to have incomplete closure of the eye. They're going to be unable to purse their lips. And again, you want to look at, all the cranial nerves. You want to do a really good neuro exam. Limb strength, coordination, gait, everything. Don't miss anything at all. And we're going to talk about this more when we get to, migraine as well. You can keep from doing all the scans and everything as long as you do a good job with your assessment. So you absolutely have to do all of these things before that you can say, hey, this is Bell's palsy. Anything out of the ordinary at all, anything affected other than that 7th cranial nerve, and it's not going to be Bell's palsy. So, go slow and pay attention, and you're not going to have to, do a big workup for these people. All right, for diagnosis and treatment, this is something that a nurse practitioner can take care of, no problem at all. And we do a diagnosis with history and physical exam. There used to be a time that, we did a big workup and everybody got a CT scan and all those kinds of things, but we've really moved away from that, and diagnostics are not required unless we can figure out there's some kind of underlying cause. Now, of course, we're not going to figure out those kinds of things unless we do our good subjective data collection. So, don't forget what we nurse practitioners are really good at, and that's subjective data. So once we have made sure that it is Bell's palsy, we want to give them prednisone for 10 days, the first 5 days at 60, and then you can start to taper. Don't forget that you always need to taper. Steroids, if you give it more than 5 days, you'd really need a taper. I mean, some sources are pressing it out to 7 now, and you will see that, but people get really uncomfortable if you just stop it, so taper. Antivirals, cyclovir, Valtrex, a lot of people are using those, and that's fine to use it in combination. I would probably do both just to be on the safe side, just because the research is linked to the herpes virus, but never use it as a monotherapy. Your prednisone is your primary therapy. Antiviral is maybe, maybe not kind of therapy. take a really good look at their eyes. Eye care is a priority, and as nurse practitioners, we really don't have a lot of good experience about that. I mean, we can tell them to get artificial tears and those sorts of things, but as far as how to tape their eye and patch and all that sort of thing, I just really wouldn't feel comfortable that what I was telling them to do was exactly the right thing to do. So if they had incomplete eye closure, I would probably go ahead and refer to an ophthalmologist. You can, take care of this yourself. I would definitely have them come back in a week, no more than 2 weeks. Even though this can resolve on its own, what if it gets worse? What if some other neuro symptom turns up? Just don't let it hang out there. Bring them back and make sure that everything's going okay. And then if anything changes or anything worsens or they're not getting better, then you've got to refer that out. Incomplete recovery after 3 months would be an ENT, and that would be someone like, how do I, if you're trying to figure out, okay, how do I, you just said neuro, refer to neuro. Well, any kind of neuro symptoms that they're having or anything new, that goes to a neurologist, okay? But if it's just Bell's palsy and nothing else, but they don't seem to be getting better, then we're going to go ahead and send them to ENT. Be very symptomatic, sympathetic, I mean to say, with these patients, because this can be a real problem. Think about the age group of who it affects, and think about the amount of disfigurement that you can get from this, and the fact that most everybody gets better, but sometimes people don't get better, and they get on the internet and they worry about this. So have them come back so that you can reassure them and talk with them and be a good listener for them, because this is going to be something that they're really worried about. All right, so not so much to know about Bell's palsy, except that you better know that it is Bell's palsy. All righty.